This is Baylor Healthcare System's Healthy Hangout. We're going to talk today about lung cancer, how to catch it in time, and how to prevent it. I've got four esteemed colleagues with me. I'm going to let them introduce themselves one by one. First, Dr. Wiley.
Hello, my name is Dr. Sharice Wiley. I am an internist here at Baylor, downtown Baylor, and I practice internal medicine at MedProvider.
Dr. Patel.
Hi there, I'm Jay Patel. I'm an interventional radiologist at Baylor Irving Hospital.
Dr. Kanduri.
Hi, I'm Karthik Kanduri. I am a medical oncologist at Baylor Salmons Cancer Center. I direct the lung cancer center at Baylor.
And Dr. Kaitan.
Roger Kaitan here, and I am an internist with Baylor Dallas.
So the topic is lung cancer. It's a big problem in this country. It's a big problem worldwide. One of the leading causes of cancer deaths in the world, and certainly in this country. The U.S. National Cancer Institute says that 1 in 14 men and women in this country will die of lung cancer. A lot of folks. So what can we do about this? Who's most susceptible? Well, of course, smokers are the biggest group. They're the hardest ones to treat. People have trouble quitting smoking. Dr. Wiley, what do you tell your patients who smoke? Sure, they know they need to quit. How do you help them through this process?
Yes, this is something that I actually spend a lot of time on because smoking is linked with so many other diseases. I know today we'll be focusing on lung cancer, but one thing that I tell my patients is that it's a process that you actually can do. Sometimes it takes people 8 times to quit before they really quit. There are medications that are available. There's a process by which I recommend for my patients, and that is taking out 1 cigarette per week until you wean yourself off tobacco. The important thing to know is that once you quit, you actually do reduce your risk of developing lung cancer. Many times people don't believe that, and they may continue to smoke, but it's important in the primary care setting to stress to patients that quitting is important and it really does make a difference.
Well, good, very good points. Now, I've had patients that have said to me, Doc, I'm not suicidal, I'm not depressed, I don't have a death wish, I just can't quit. So it's hard to quit sometimes. Dr. Kaitan, what can you do else to help patients that really want to quit but find they can't do that?
Well, recently, as you know, David, there's been that issue where we've been adding electronic cigarettes. And the electronic cigarettes have been one of the ways to help people quit because sometimes it's an oral fixation that people just can't stop holding something in their mouth either. I've also had them go see a psychologist. We've used Nicoderm patches. We've also used some medications like Chantix. A lot of people are a little worried about using that medication because of very bad side effects from nightmares. But we always start them off with the medication. We are there with them. And then I usually have a lot of my patients call me weekly to tell me how they're doing in regards to smoking cessation and if the plan's working for them. Usually we give them 2 to 3 weeks to see if it's starting to work. If it's not, then we'll try to change something to another method, either pharmacological, psychological, or the e-cigarettes.
So a lot of techniques, a lot of tools to help people who do smoke. I guess the big message is if you don't smoke, don't start. It's really hard to get off of nicotine. It's very, very habit-forming. The drugs sometimes help, sometimes work. Counseling can help. A lot of techniques are available right now. So if you are a smoker, if you have been a smoker, if you live with a smoker, if you've had prior lung cancer, all those things increase your risk of lung cancer. Our problem in this country is finding it in time. That's the key. Dr. Patel, chest x-rays, those have been around a long time. There's some controversy whether they even work to find lung cancer in time. What's your opinion about that?
Yeah, you're absolutely right. Chest x-rays have never been shown in any large randomized clinical trial to help adequately screen for lung cancer. And so in the past we've used chest x-rays, but unfortunately lung cancer has to be of a big enough size to detect by a chest x-ray. And a lot of times when you detect it by a chest x-ray, the lung cancer has advanced to the point where it's not curable. And that's where the new National Lung Screening Trial came into play. This is a large study that involved 54,000 patients, and it came out in the New England Journal of Medicine about 2 years ago, and it showed that by screening patients with low-dose CT scans, we were able to significantly decrease the mortality rate from lung cancer. And so the whole paradigm of screening for lung cancer has changed because of this large trial. And now more and more agencies are coming out with recommendations that patients that are at high risk for lung cancer should be screened for lung cancer using these low-dose CT scans. And just a note regarding these scans, they are called low-dose CT scans because the amount of radiation is extremely low. It's about 5 times lower than a traditional CT scan of the chest. And so it's a very safe low dose of radiation for the patient, and we're able to detect nodules that are small enough that can offer the patient a cure if it is indeed lung cancer.
So the key is finding lung cancer earlier. The chest X-ray is not sensitive enough, but these new CT scans are more sensitive. So you're finding cancer earlier when we have a better chance to treat it.
Absolutely, and that's the whole problem with lung cancer, is that symptoms are typically late in the disease process, and so if there's a good test out there that will allow us to scan these patients and detect these lung cancers before symptoms develop, especially in a high-risk population, then we're able to offer more likely a cure for the patient. So these low-dose CT scans are very, very sensitive. The downside to the low-dose CT scans is that it will detect several things that are not lung cancer but can be confused for lung cancer. There is a high false positive rate as well, but overall it's a very sensitive test.
Let me go back to Dr. Wiley. Dr. Wiley, some of my patients are very nervous about CT scans. They say these things have radiation. Can they cause cancer? Is this something that we ought to be doing on a regular basis? What do you tell your patients, Dr. Wiley, about getting screening with CT scans for lung cancer?
Well, just as Dr. Patel pointed out, the amount of radiation or the amount of contrast that's in this type of screening test is very low to minimal. So I encourage them to go ahead and have this done, because the risk of not doing it and, you know, omitting cancer is far greater than the risk of the exposure to the iodine or contrast, because it's a minimal amount. So I go ahead and I encourage them that and let them know that it's an okay test to have done.
So I guess we need some guidelines here. Who should be screened? How
Sure.
often should they be screened? Dr. Patel, are there some guidelines that can help guide us with this thought about screening?
Yeah, the guidelines that we use here at Baylor are kind of reflect the guidelines that were used in this large national lung screening trial, and they include patients that are between ages of 55 and 75, and those that have a 30-pack year history of smoking. And what that means is if they smoke 1 pack a year for 30 years, that equals a 30-pack year history. On the other hand, if they've smoked 2 packs a day for 15 years, that also equals a 30-pack year history. So if you fall into that high-risk category, then lung cancer screening is recommended for you. Also, if you're a former smoker but you have quit within the past 15 years and you have a 30-pack year history and you fall into that age range, then you also are considered in that high-risk group. Now, the definition of high risk is or could potentially change and may include patients who've got a history of asbestos exposure, who've got a history of significant secondhand smoke exposure. So that may change, but as of now, the high-risk category is defined by patients between ages 55 and 75 and with a 30-pack year history.
Dr. Caton, are you having any success talking patients into getting these CT scans on a regular basis?
Yes, actually I've had 2 people who recently had the CT scan done, and actually both got diagnosed with the lung cancer. In fact, Dr. Kanduri is taking care of one, and one of his partners taking care of the other one. So it's been very successful for me. The one thing that I just want to warn the public about is that sometimes we're still having a lot of trouble with insurers getting pre-authorizations and paying for the CT. So one of my patients actually had to pay out of pocket for the CT, and the radiology department is very nice about helping them out with all those issues. So it's one of the things that hasn't come up to favor yet with insurers.
Dr. Kanduri, this has to be good news for you. You treat lung cancer. You're a medical oncologist, so are you finding patients referred to you earlier now when you have a better chance to treat them?
It's a new imaging modality. It's a new screening parameter that got recently approved by multiple agencies, as Dr. Patel was talking about, including the USPSTF, which came out with a recommendation to go ahead with screening. So as Dr. Ketan was talking about, it's still not fully commercially available through all insurers, and through Baylor we have a low-cost program for screening. So having said that, we are starting to see an increased number of patients going through the programs where they are able to do the screening, and then if they are diagnosed with something that suggests lung cancer, they do come to us. We are starting to see a slight increase and pickup in this issue, in this rate.
And let's emphasize the point: the earlier you find cancer, the earlier your drugs work on them. Dr. Kanduri, tell us about that.
Well, the first thing is, just like Dr. Patel was talking about, the big issue about the National Lung Screening Trial, which is the first so-called parameter or a screening trial that has been found to be positive. Previous trials and a large trial called the PLCO trial with chest X-rays have never found any positivity. Sputum screening has never been found to be positive. What this trial particularly showed is if you catch the cancers early, you will be able to reduce the risk of dying from lung cancer, which is the golden point or the specific thing that we are looking from a screening modality. So if we find those tumors early, those patients have the chance of having them operated upon early or treated in other ways, even if it does not include an operation. And therefore it reduces the chance for it to spread, and what was proven in this trial was the most important thing, which is it reduces the risk of death. Of course, if you catch them early, you can also consider treating them aggressively if necessary, depending on the stage of what the tumor is, with other modalities, including chemotherapy, which is given by physicians such as myself.
You know, we talk about prevention. We love to prevent diseases rather than wait until they're advanced and we have to treat them with more complicated techniques, medicines, operations. How about prevention? What can we do to prevent lung cancer, Dr. Ketan? What's the
number one thing to prevent lung cancer is stop smoking or don't start smoking. It's the number one thing. And I mean, we talk to younger kids. I know Dr. Wiley and I have a lot of population youth who are in their 20s to 50s. And they are actually, a lot of the 20-year-olds are starting to smoke again, and we're really trying to catch them and tell them this is not a good idea because of the long-term effects from other diseases. But the number one reason, stop smoking.
You know, and people in this country have got the message overall. There's less smokers now than there were before, but this new trend, Dr. Wiley, is for young girls to smoke. It's a trendy thing they're doing. I don't get this. Are they not getting the message? What can we tell them?
You know, I appeal to people based on the population, and for young women, I try to appeal to vanity for them. You know, I try to tell them, you know, it causes wrinkles, aside from all the health, you know, causes. But I try to appeal to them and to explain to them the importance of quitting smoking. But I don't know what's caused this, you know, this new trend to start smoking. I think a lot of it has to do with their parents. If they see their parents smoke, or if they grow up in a home where smoking is done, then that will sometimes lead them to smoke. But as I stated, I try to encourage, I do a lot of counseling about quitting smoking, because it's the number one way to prevent lung cancer.
You know, when most people with lung cancer have smoked, but not everyone. Dr. Kanduri, what else causes lung cancer? Why do some folks who've never smoked get lung cancer? Do we know the answer to that?
Well, we don't know all of the answers, and we are in the search for the specific reasons. But we do know that there are secondary causes, like secondhand, or what is also now in fashion called as third-hand smoking. There's risks of radon exposure in homes and around the houses, issues with chemical exposures, including some things like what Dr. Patel talked about, beryllium, diesel fumes, silica, etc. But you're right, there are a big proportion of patients, roughly about 15% of all lung cancers diagnosed, and perhaps even a little more nowadays, where patients have never smoked and may not even have any particularly clear exposure that they can relate to, and yet have lung cancer. Many of these people are in their 40s to 60s. Many of them are women, but that's not necessarily just one particular way of looking at it. They are all types of people, but a lot of them are particularly never smokers. When they tell us the history that they have never smoked, and never smoked doesn't necessarily mean never touched a cigarette in your life, but the loose definition is somewhere about 100 cigarettes in your lifetime, and no more than that, or roughly about that. If they tell us this, it triggers in our minds a suspicion that there may be other factors to play. Even though we do not know the specific reasons as to why such things happen, but there are circumstances where mutations or changes in the tumor profile occur. We can test for them, and we are testing for them in all the large institutions and many community oncology clinics, etc. So the test looks for particular changes in the tumor's DNA, which then allows the tumor to grow and therefore expand and spread. The various things that have happened are that once we start finding what that particular mutation or change in the DNA is, then you can hopefully bring in what is called a targeted therapy to try to treat these patients to get a maximal response. We have some of those targeted therapies in the market that actually show a significant benefit in trying to shrink these tumors down and allowing for a good response and improvement in quality and quantity of life for these patients, especially when their tumors might have spread, etc., to other parts of the body. But the search continues to go on. We have, in a large studies, found that approximately 50 to 60% of patients who have lung cancer might have a mutation that we could potentially target. And that is the new era of lung cancer, where it becomes personalized to that individual patient, where testing is done for further evaluation.
So, Dr. Patel, the study that came out that you referenced is about screening people who smoke. As a physician, as a radiologist, do you also think it's wise to screen other people besides smokers? Should we talk to people who live with smokers, maybe have had lung cancer before, maybe a family history of lung cancer? Who else should be screened with this new technique, this low-dose CT scan?
Yeah, I think that's going to be up to the patient and their primary care physician, who would normally order such a low-dose CT scan for screening. If in a conversation the patient and the primary care physician feel like that patient is at a high risk for lung cancer for whatever reason, whether it's prior asbestos exposure or a strong family history of lung cancer, in addition to the other risk factors we mentioned, then it's up to the patient and the physician to decide if that patient is appropriate for screening, because I think the definition of high risk, as I mentioned, will be changing in the future. The inclusion criteria for the National Lung Screening Test or trial was very strict, but I think there are other patients out there that are still at high risk for lung cancer, and so it's going to be ultimately up to the patient and their primary care physician to decide if they are at high risk and if it's appropriate for them to be screened with a low-dose CT scan.
Dr. Kanduri, 2 weeks ago, the World Health Organization came out with a statistic that said that worldwide there are 225,000 cases of lung cancer due to pollution. This was actually publicized and made a big deal out of that. Are they talking about folks in this country? Should we worry about that? Is this mainly in countries that have more pollution than us? Is it really a risk factor? Are these many lung cancers caused by pollution? What's your view on their recommendations or their announcement about this?
I think pollution is a well-recognized risk. As I mentioned, there are secondary exposures that we cannot clearly quantitate. Even secondhand cigarette smoking exposure cannot be actually quantitated to tell how much one has been exposed to. And in that same vein, one could not tell how much of an outside pollutant you are exposed to. And there are so many pollutants in the environment, including in the air or in contact with other chemicals that people come across. So it definitely has a clear role to play in the increased risk of lung cancer incidence. So I'm not surprised. In fact, I'm in agreement with the view about the fact that there is definitely a cause-effect relationship with this particular problem. One just can't put one's finger and say specifically this much will cause a specific incidence or increase. One just has to be aware of it and improve one's sanitation, one's environment around. As I said, radon exposure has been well recognized, and radon is a ubiquitous compound that many houses around have and we're breathing it in and out. So one can test for it. And similarly, other environmental pollutants can have a role to play. As technology improves and as the information increases, we will be able to recognize and delve into them much more deeply. But at this time, I think one just can safely say, yes, there is a definite link, in addition to, of course, the largest being, of course, cigarette smoking. But there is definitely a link, and one just has to be cautious to understand that.
So Dr. Wiley, what do you do with this information for your patients? Should patients not jog downtown on high ozone days? What do we tell them about pollution as a potential risk factor for their health?
Well, certainly, you know, we do have warnings. It's on our news about high ozone days, but we have to keep these things in perspective. You know, as we've all pointed out, there's no, you know, clear connection. You still have to go about your life, you know, and do the things that you enjoy. You know, I think the important thing is to make the public aware of the highest and the known risk factors, as well as to, you know, inform them of potential risk factors. But we can't live in a bubble, you know. We have to continue about our daily lives, and we can't live in fear as well. We have to, you know, take the information and just put it in perspective according to our personal risk factors in our lives.
So Dr. Patel, back to you. For folks that are at risk for lung cancer, how do they get a low-dose CT scan? How would they go about that today?
Well, our mechanism is that we have the patient discuss lung cancer screening with their primary care physician. That physician will then order the screening test just like they would order a mammogram or a colonoscopy. And here at Baylor, what we do is the patient comes here, gets the scan. It takes about 5 minutes, and we typically get the results to them, or to their primary care physician the next day. And we also have a navigator here as well, which I think is really important to have, in addition to a multidisciplinary team at Baylor that can digest that information and decide what's appropriate if there is anything next for the patient. So what we encourage is, if you're a patient who feels you're at high risk for lung cancer, or you want to get screened for lung cancer, discuss this with your primary care physician, and then the test can be ordered through your primary care physician. Right now, the lung cancer screening test, the low-dose CT scan, is not covered by insurance, but we're offering it here at Baylor at a very low cost, less than $200, and ultimately I think it will be covered by insurance companies, and even the Affordable Care Act will, I think, ultimately cover this as an appropriate screening test for those at high risk. And then once the patient receives their scan and it's analyzed, we have this multidisciplinary team that I referred to that actually will review these cases and decide what's appropriate. And that could range from a follow-up CT scan a year from now, a follow-up CT scan 6 months from now. It could also mean a biopsy. It could mean any other form, or a whole variety of additional tests that may need to be performed. So we analyze each case individually and decide whatever is appropriate for the patient next through a multidisciplinary effort.
So Dr. Ketan, I want to give you the last word. What's the best way we can decrease the incidence of lung cancer in this country and worldwide? What are you going to say to folks?
Stop smoking. That is the easiest thing to do. Smoking, 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 bad, bad, bad. Stop smoking.
Thank you, and thanks to everyone for watching. This is Baylor Healthcare System's Healthy Hangout. We hope to see you in the future for another great discussion about issues that affect your health.